I would like to welcome everyone to the 6-month progress report. In the upcoming few minutes, I would like to introduce you to my PhD. It's titled under Assisted Reproductive Technology. I am Begüm Kepkep. I'm from Istanbul, Turkey. I have a TDK student, and we share a vision with our team that we have decreased psychological burden on couples who are going under assisted reproductive technology. And to meet our vision, we have a mission to find a safe and effective technique to increase the success of assisted reproductive technology. We have 2 ongoing projects, and the first one started in September 2024, and the second one started in November 2024. Let me introduce you the first one. It's titled under Investigating the Effect of oocyte gene mutations on fertility outcomes during assisted reproductive technology. Infertility is becoming a global issue, as we all know, and around 15% of couples are having trouble conceiving. And we have a therapy which is called as assisted reproductive technology. And even though with the use of ART, unfortunately, some women still cannot conceive, and this can be due to a phenomenon called total fertilization failure. TFF occurs in every 5 to 10% of IVF cycles, and there can be various etiologies behind this phenomenon. One of these etiologies that we find that can be a cause is the oocyte gene mutations. Some examples for these oocyte gene mutations are WEE2, PATL2, and TUBB8. These mutations interfere with the oocyte maturation phases and cause fertility failure. We can make a genetic panel as a result of our research. So our aim is to conduct a research which investigates the relationship between oocyte gene mutations and total fertility failure. We have a clinical question of does having certain oocyte gene mutations increase the risk of total fertility failure and lower the fertility rates. We are using a PECO framework for this project in which the population is women undergoing ART. The exposure is oocyte gene mutations, and the comparator is no mutation. Our primary outcome is total fertility failure, and our secondary outcome is fertility rates. We hypothesize that having certain oocyte gene mutations increase the risk of total fertilization failure and result in lower fertility rates. Our clinical and research implication is to be able to create a genetic panel according to our results for the ART patients. We have key articles for our mutated population. The strengths of these articles are that genetic test is done for all of the population of the participants, and the detailed patient data is given for all of these patients. And the IVF cycle information is also given per patient in these tables. However, we have a great limitation that these studies are single-arm studies, and they do not report any data about the non-mutated population. Therefore, we are using 2 sets of key articles and articles in general, in which we are using the mutation articles for the mutated population, and we are using general articles for the non-mutated population. There can be a question that how can you use general articles and assume that these do not present any gene mutations? We can say this because the prevalence of these gene mutations are lower than 0.1%. We have 2 domains for our search key, and we conducted our search on 3 databases. As you can see, after all of the selection processes, we have 170 from our systemic search, and we have 83 more articles from the citation chasing, which is a big pool. So we are currently on data extraction phase with my co-investigator and with my TDK student, and our deadline is Sunday of March. Let me skip to the second project, which is investigating the effect of antioxidants in IVF media, on the use of antioxidants in IVF media and fertility outcomes during assisted reproductive technology. As we discussed, ART is used by infertile couples all around the world, and there are over 500,000 IVF deliveries every year worldwide. We have the cellular metabolism going on through this ART process because we are using an in vitro media. We have to give everything exogenously. As the cellular metabolism keeps going on, we have the production of reactive oxygen species. And these ROS accumulates over the course of embryo development. This ROS negatively affects the IVF outcomes. And however, this ROS can be reduced and counterbalanced by a variety of antioxidants, such as acetyl-L-carnitine and acetyl-L-cysteine and alpha-lipoic acid. We aim to see the positive outcomes of on fertility of using these exogenous antioxidants. Our clinical question is, does using antioxidants in IVF or EC media result in better fertility outcomes? In this project, we are using a PICO framework in which the population is again women undergoing ART. The intervention is antioxidant use in IVF EC media. The comparator is no antioxidant use, and the outcomes are fertilization rates, pre-implantation, embryo development. We hypothesize that using antioxidants in the culture media results in better fertility outcomes. Our clinical and research implication is that we increase the rates of fertility. This one is a preliminary search key, so it still needs improvement, but this is where we are right now. We have 2 domains again, but we still have to discuss with our SMS. As a summary, we have 2 ongoing projects, and we would like to submit the first one in September 2025 and the second one in February 2026. So I would like to end my presentation with a quote from Albert Einstein. It's not that I'm so smart, it's just that I stay with problems longer. And thank you for your kind attention.
I have a question. How do you measure in the first and how do you plan to measure in the second project of yours the fertility outcome?
By measuring the fertility rates, how much of the oocytes get fertilized and how much of them go through the embryo stages of how many does not arrest in the early stage and can progress to the pregnancy.
Okay, thanks. And you don't plan to follow up with like pregnancy or successful pregnancies? It's just only like on the ART level? Yes,
right now we're more planning for the molecular phases and not the pregnancy, but if we have enough data, of course, we can do the pregnancy outcomes and live births even.
Thank you very much.
Thank you.
Just one really short remark. Congratulations. I saw that you screened 12,000 papers, so it's a lot. I mean, I know the policy of the Translational Medicine Center, but I really like to keep stuff up to 4,000 or maybe 6,000, and then we have to split. I know now it's your full work, or you got 4 days per week for these projects, but you should really choose that for which projects it's worth screening through 12,000 papers. But this is just my general remark. I know the policy is different because, you know, to be more comprehensive, and you cannot really predict at the beginning which paper is going to be practice changing or big and which is not. So it's good if you have time, but this is a lot, so congrats. And for all of you who screen through this huge amount of data.
Yeah, I would like to thank my co-investigator and my TDK student for their great help. So thank you, guys.